This short video presentation is brought to you by Doctors Appraisal Consultancy and gives a brief overview of how you can provide quality improvement evidence for your appraisal. It is particularly directed at aesthetic doctors, although the general principles of what constitutes quality improvement would apply to any doctor's scope of practice. The current regulations for appraisals and revalidation state that all doctors have to produce some evidence of quality in their clinical work each year. In other words, they are providing evidence that they are providing good and safe care in relation to their scope of practice. For aesthetic doctors, this would mean looking at their clinical work from the viewpoint of established clinical standards and reviewing the clinical outcomes of their work. Sometimes this might include looking at specific clinical cases, reviewing significant events that occur, or reflecting on the doctor's teaching and training roles that they make up part of their work. The gold standard of providing quality evidence for doctors is widely accepted as providing a clinical audit, and this implies looking at a standard in relation to the clinical care being looked at and measuring your own work against this quality standard. There have been many definitions of clinical audit, but one commonly accepted description is that clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and the implementation of change. A more general definition describes clinical audit as a way to find out if healthcare is being provided in line with standards and lets care providers and patients know how their service is doing and whether there can be any improvements. The aim is to allow quality improvements to take place where it will be most helpful and will improve outcomes for patients. To set out a clinical audit for your own practice, you need to know the difference between criteria and standards. Criteria are simple statements used to describe a definable, measurable item of healthcare which describes a quality and can be used to assess it. Examples are: patients should wait no longer than 15 minutes in the clinic prior to consultation. All aesthetic medication for injection should be within their expiry date. All doctors providing invasive procedures should have hepatitis B immunity, and post-operative infection rates following cosmetic surgery procedures are within an acceptable rate. The standard is different in that it describes the level of care that can be achieved for a given criterion. Examples of this would be 80% of patients should wait no longer than 15 minutes before a consultation. 100% of aesthetic drugs are within their expiry date, and 100% of doctors providing invasive procedures have a current hepatitis B immunity certificate. Using the above examples, you should be able to devise criteria and standards in relation to your own clinical practice. Please note that clinical audit is not an observational study or clinical review or a survey. There is often confusion with the term audit, as many people think it is a counting exercise, but as described here, this is not the case, and it is specifically measuring clinical work against established standards. So examples from aesthetic medicine of clinical audits you could consider include prevalence of skin burns following laser treatment for aesthetic problems, post-operative complication rate following cosmetic surgery, review of adverse events against national data, comparison of practice data against an organization's annual audit, and the record of the batch and expiry date of dermal filler toxin products. Providing an audit in aesthetic medicine is not always straightforward. There are some challenges in relation to the fact that currently there are limited resources for clinical audit, little research evidence, and a lack of national data. Sometimes audit development is not seen as a priority, and there is a difficulty in identifying comparative data. However, this is changing gradually, and the more doctors that provide robust clinical audits, then the more comparative data we will be able to present. Once the clinical audit has been completed, reflection of the results and the conclusions from this should be recorded. This can be usefully described by summarizing what the audit has achieved, what are the main learning points and benefits, what problems are encountered, and crucially, what is the impact on your clinical practice. It may be helpful to look at real examples of quality improvement evidence that aesthetic doctors can provide. A doctor considering their clinical work wanting to review the pre-treatment assessment of patients and considered that a relevant standard would be 100% of records contain pre-treatment photographs for every patient who was having an aesthetic treatment. For your own practice, you may well have been providing clinical reviews for some time, so the next step would be moving from a clinical review to a clinical audit. In order to do this, you need to choose a relevant topic, which is the criteria, and then from this identify an appropriate clinical standard. You can then plan your work by looking at established audits, collect data using realistic numbers, and then of course calculate whether or not the standard has been met. Reflection on your conclusions would follow, and you may wish to consider appropriate practice changes to improve standards going forward. Finally, a re-audit can be used to check whether or not the changes have produced a benefit. When designing an audit template for your aesthetic practice, clinical audit is helpful to look at some standard areas. Firstly, you should look, why are you doing the audit? What is the relevance to your scope of practice? Then consider what is best practice. Is there an authoritative opinion or research evidence in relation to the criteria you are looking at? You should then describe the suggested criteria or indicators in relation to your practice, and from this, proposed standards should be developed which we would target for best practice. This would lead you to identifying the data to be collected. Once you have collected the data, you can then compare that with the national or local audits if these are available. As stated previously, you should write a reflection report on your results and conclusions. Although we have said that clinical audit is considered one of the best ways of presenting evidence of quality in your work, appraisals can contain a wide range of other types of evidence of quality. These might include follow-up review consultations 3 weeks after an aesthetic treatment, before and after treatment photography policy, a reflective diary of aesthetic treatments cases undertaken, a review of aesthetic cases with colleagues, a literature review of current best practice in aesthetic treatments. If you present clinical case studies, then this might consist of a documented account of interesting or challenging cases that a doctor has discussed with a peer, another specialist, or within a multidisciplinary team. I hope you have found this brief overview helpful, particularly if you are considering designing a clinical audit for your own aesthetic practice. Further information can be provided from Dr. Myers at Doctors Appraisal Consultancy.